Okay, bowel obstruction. So this is about an hour-long talk that I've crammed into a much shorter time. We're going to talk a bit about the causes of obstruction in cancer and how to talk about it with families. And I have a case. That's one of my favorite pictures from Nepal. If you look here, there's a little girl right there, and she was going along behind these old guys and whispering to each of them, and they were laughing each time she went, and I'd love to know what she was saying to them. So a brief case. Norman was a lovely guy from Gabriola. He had a cecal carcinoma and presented a few years later with obstructive symptoms. Was admitted with nausea, pain, hadn't passed any stool or flatus for days, and was obstructed. We'll come back to him. This occurs in somewhere around 5% of cancer-related terminally ill patients, most commonly with ovary and colorectal. That's not a surprise. The disease is in the abdomen. That's where the trouble is, but occurs in other cancers as well. Primarily today, it can occur anywhere in the GI system. Primarily, I'm going to talk about intestine, so from gastric outlet to the end of the tube. Small bowel, most common. Large bowel also, it's often mixed or both. It can be single or multiple sites of obstruction. It can be partial or complete. That's not always easy to tell. And it can be malignant or benign causes. The common thing is occlusion of the lumen of the bowel. As Jeff had in his slides on pain, when we think about etiology, I like to divide things. If you want to have a little framework for how you think about stuff, I first try and think of things that are directly related to the cancer. So is it the tumor mass causing the obstruction? Has the tumor invaded the mesentery and is affecting the propulsion? Is there a torsion? Is there massive ascites or paraneoplastic syndrome? The ascites doesn't have to be massive, but it has to be tense. We have a fellow who's in our unit now who was really not very distended, but he had obstruction. I wasn't really thinking he would have much ascites at all, but we sent him to radiology and they drained 7 liters from a guy who really didn't look like he had much. And as soon as we drained the ascites, his bowel started to work because all that pressure was gone that was just functionally blocking his bowel. So it can be related to the cancer, or it can be related to the cancer treatment. So adhesions from surgery or radiation. You can get chemotherapy, can cause ileus. Or it can be indirectly or related to the cancer or unrelated. So constipation, ileus from drugs, peritonitis, bowel infarction, and other causes. A significant number of these are benign causes. If you operate on somebody with bowel obstruction, about 1/3 of them are benign causes, meaning adhesions or torsion, not necessarily directly from cancer. So when you diagnose it, the usual history and physical and imaging. Now for you guys, the imaging will be more challenging, and we'll talk a bit about that later. In this patient population, this is not so much of an acute event as you learn in the emergency room or in family practice. This often develops over days or even a week or two. The usual symptoms, cramps, nausea, vomiting, and it gradually becomes more severe and continuous. There may be a constant pain or a colicky pain, but only 3/4 of them have true colicky, obstructive kind of pain. And the vomiting is quite variable, actually. If the obstruction is quite distal in the large bowel, that may be quite a long time before they actually develop nausea and vomiting, like even a week or more. Plain radiographs are okay. CT is the gold standard. The high-resolution CT scan just gives us fantastic pictures of the abdomen, and the radiologist can find the dilated loop of bowel, and they kind of scan through them, and they can follow it to where the obstruction is, and often can say, that looks like adhesions, or there's a tumor mass there causing that. In your population, you need to decide, is it appropriate for the stage of illness this patient is at? What are you going to do about it if you get the scan and prove a particular kind of obstruction? Are they an operative candidate? Would you transfer them to the hospital for surgical intervention? And if you're not going to do any of those things, then you don't want to do the test, right? So it always depends on the context. Will our investigation actually change the management? You can take your time. Again, this is rarely an acute emergency. You can take a few days to sort this out. You treat the symptoms, but you can sort out the obstruction and your plan over a few days. And you have to choose what's the right thing for this particular patient in the place and the context of where they are. Main areas of symptom control: always treat the pain, nausea, vomiting. Sometimes they're pretty thirsty, so we might give them some fluids, modest amounts of fluids. This is not surgical rehydration kind of stuff. We might give somebody 50 mils an hour of fluids. So the management is really highly specific depending on the stage of illness, the type of obstruction, what is their prognosis and performance status, and what do they want? What are their goals and choices? So we're going to talk about active surgical medical approaches and comfort care. So back to Norman for a minute. On day 2, he was actually in pretty good shape for an older fellow, and a decision was made to take him to surgery and try and fix this problem. But unfortunately, he had diffuse carcinomatosis, so mental caking, and it was not at all resectable, and even a bypass procedure, a colostomy or something, was not possible in him. That shows, in this case, CAT scans are not helpful. The carcinomatosis, where you have those thin layers of cancer spread throughout the abdomen, on the omentum and on the bowel, that does not usually show up on CAT scans. And it's not that uncommon for the CAT scan to show, gee, it looks pretty good, there's not very much cancer there, and the surgeon opens them up and they're just loaded with cancer. He had moderate symptoms at that point, and that was when we got re-involved with him at that point. So active surgical management, it's not routine in our population, but you need to consider it in selected patients. Particularly if it's a mechanical obstruction, it's not from chemotherapy-induced ileus. If it's a single site of obstruction, and if they have reasonable performance status. You really need to have good clinical judgment with this. Most studies on this conclude that too many inappropriate operations get done on sick patients who are far too sick, and we want to avoid that. I mentioned that some of them are benign. However, if you choose the right patients and you get a good result, some patients can remain symptom-free for quite a long time after this, many months. However, operative mortality of 10 to 20% and an equal morbidity, so we're looking at 20 to 40% bad outcomes from the surgery. So you really have to be careful with it. And the last line that also makes this harder to sort out: surgical studies rarely talk about quality of life. They measure hard outcomes, but they don't actually tell you at the end of the article whether this was a good idea or a bad idea. These are poor prognostic factors for surgery. Most of these are common sense. If they've had surgery before and it didn't work, if you know that they have widespread disease, gross ascites, multiple metastases, frail elderly, those are pretty obvious. Previous radiotherapy, the surgery's a disaster often if they've had previous radiotherapy. So they can sometimes do an ostomy of some type to bypass things and relieve the symptoms. The PEG tubes that I talked about in the nausea thing, the venting tube, can be very helpful for relieving their symptoms. Stents are an option in a few cases. The literature from the States is pretty pro-stenting. Our experience hasn't been that great. The technical success rate may be 90%, but I think in the real world, you're lucky if it's 50% successful. Other things like biliary stents and things, those are much easier decision and much more effective. But we just haven't had great results with doing, rectal stents to try and bypass an obstruction or duodenal stents. That's what they look like. They're put in, the pointy end goes through the obstruction, and then when they withdraw this, it expands and just kind of creates a new lumen. So Norman, when we saw him, he had, post-operatively, he had recurrence of his distension and vomiting. He was still on the steroids and Haldol. We increased him the steroids, moved him to the palliative care unit. It was his choice to have a nasogastric tube. He was really vomiting a lot at this point. So medical management of this, NG tube and rehydration, if you do that and wait a few days, some of them will reverse on their own with that treatment, somewhere between 30 and 50%. And again, the NG is the patient's choice. And then we move into medications for this that are pretty useful. Analgesics, we usually continue opioids by the usual parenteral route. You need to give them good pain control. If they really have colicky pain, you might try an anticholinergic to help that. Motility agents. This is an interesting thing. In 1985, the very first article on medical management of malignant bowel obstruction said, don't use metoclopramide because it causes too much cramping. But there was no data in the article that actually supported that. So when I started treating this in the early 90s, I guess I read that and I thought, that doesn't make sense to me. You know, we're trying to get the bowels moving. You need the motility agent. So for the longest time, I would write the orders, metoclopramide, 10 milligrams QID, discontinue if causes severe cramping. Never had to discontinue it in years and years and years. So I have always included that in my mix. And yet, if you look at articles on malignant bowel obstruction, they still will say don't use metoclopramide. But if you look at their references, the references all go back to that original article where there was just an opinion that said don't use metoclopramide. So it's kind of an interesting medical myth thing. So my approach is I use this in everybody and I would discontinue it if I thought it caused severe cramping. Anti-nauseants, the metoclopramide, usually we'll add Haldol into this. Steroids, pretty good data that steroids help reverse malignant bowel obstruction. And then this drug has been very helpful, octreotide. This dramatically reduces the secretions in the stomach. And there's also some complicated physiology where it prevents the distension of the lumen and the collection of fluids in the lumen of the bowel as well. And there are actually some pretty good studies on this, and you can get really very good control of the nausea and vomiting, and quite often reverse the obstruction using this combination of drugs. A study came out of Grenoble a few years ago looking at this, and they kind of staged this where it was the first step, you can see there, NG, hydrate Haldol. Then if they were still obstructed, they would add the octreotide, and then finally was a gastrostomy tube. And they had symptom control in 90% without using an NG tube. So I looked at that and I thought, it's a little different than what I'm doing because I'm doing everything at the beginning. And my point is, why would you wait? If octreotide is a really good drug for this, why would you wait 5 days before you add it? It used to be very expensive, but it's not anymore. It was $300 a day when I started using it. Now it's about $30. So our approach is basically give them just about everything. So everybody gets comfort care, manage their pain, manage their nausea and vomiting, mouth care, careful attention to mouth care. The nurses are usually very good at that and good at teaching the families. Nutrition, that's really more it's usually more of a conversation about how nutrition doesn't really help in this situation, helping the family understand what's going on. That's a whole other talk by itself. Comfort care only in the very advanced stage of disease. This is an important point. Patients are often told if you have a complete obstruction, you're going to die in 2 or 3 days, and that's actually not true. The average is 10 to 20 days. And so they need to be prepared for that. It's very hard on people if they're told it's only going to be a couple of days. There's sort of two parts to that. You know, it's only a couple of days you have to put up with these bad symptoms. Can you do it? But also, you know, in terms of preparing with family and tidying up their tasks at the end of life, it's usually 10 to 20 days. So with Norman, we started octreotide, metoclopramide, and steroids. This worked really well. His bowels remained open. He was in our unit for 2 weeks. Then he wanted to go home to Gabriola Island. We sent him home with the same medications and a low residue diet. He was actually eating a little bit. And he lived for a month at home. So my overall approach, if it's really urgent, NG suction, give the patient the choice. Start optimal medical management in almost everybody, unless it's really end stage. And our usual cocktail is metoclopramide plus octreotide plus dexamethasone and usually Haldol. We don't do this, but you can combine them all in one pump and give it together. Consider your hydration options. It may reduce nausea. And then decide if you're going to do any other investigations. Is this person a surgical candidate? In some people, an acceptable level of control, maybe they still vomit once a day or twice a day. But if they don't have nausea all the time, most people are okay with that. If they can get this down to throwing up once a day, they feel, 5 minutes of nausea, empty their stomach, and then they're okay again. Most people are okay with that. That's it.